Himanshu Arora. Mr. Arora is the Chief Data and Analytics Officer at Blue Cross Blue Shield, Massachusetts. He is responsible for advancing the company's data science efforts. He is an analytics leader with a background spanning healthcare, insurance, government, and financial services. Mr. Arora previously served as Head of Data Science and Analytics Enablement at Healthcare Services Corp. And health positions at Zurich Insurance United Healthcare and Deloitte Consulting. Welcome, Mr. Arora, welcome.
Thank you, Sherry. Really excited to be here, and two really high-powered presentations and presenters to follow. So thank you to Dr. Hightower and Dr. Sambamoorthi. So I'm going to talk a little bit about how we here at Blue Cross Blue Shield Massachusetts are approaching the space. Before we do that, a little bit about Blue Cross Blue Shield Massachusetts. We are a single state, not-for-profit, community-focused Blue Cross plan. And beyond the commercial objectives of any entity in the space, we feel and have been accountable to the community over the decades of our existence. And while AI is a hot topic today, bias, as we know, has existed in healthcare, in society in large, for much longer than AI has been a topic of discussion. And when we go back and look at the work that we as a company directly and through our foundation have done in the space, there's a lot of heritage and foundation and excellent outcomes to build upon, right? So this is when we think about bias and debiasing healthcare delivery, healthcare coverage, that's been a primary focus of ours for a long time. If we go to the next page, please. So this focus on debiasing and continuously and turning it into a discipline and not just a one-time activity shows up all over the organization. It shows up in how we approach the space, how we approach AI as well. And as you see highlighted here, both as Dr. Hightower and Dr. Sambamoorthi referenced, when we think about governance, when we think about risk management, when we think about audit capabilities, this is a prominent part of what we focus on as we are building towards the exciting capabilities that AI offers, and have been doing this over a sustained period of time. If we move forward to the next page, and this is again to sort of really hammer home this point, when we think about our risk tolerance from an AI perspective, we are very clear about the fact that we have a zero tolerance policy for any AI systems that exhibit any discriminatory behavior. So this is something that is not something that we think about in the end, if you will. It is a focus area. It is something that is front and center from the beginning, all the way, again, going back to Dr. Hightower's presentation, to thinking about what problems we solve for, what problem areas we focus on, how do we understand each individual member, population groups, health conditions around it. It goes all the way back to the definition, and then all the way forward to measuring the healthcare outcomes for individuals, for communities, for the society at large. It's an end-to-end spectrum for us. If we move forward one more page, please. So again, a lot of this was covered in the previous presentation, so I'm not going to spend too much time on this. But the point of this is to say, look, the positive impacts of AI on healthcare are really, really exciting, right? And especially with generative coming into the picture, when we think about the categories of care that can be improved, all the way from access to personalization, early detection and prevention, efficiency and cost savings, there is no shortage of opportunities in healthcare to apply leading capabilities through artificial intelligence. When we think about the negative impacts too, this is where we have to be consistent and perseverant in the application of techniques, methods, intent when it comes to debiasing, when it comes to handling and managing inequality, and of course the legal and ethical implications that it creates for us, but for all our partners, entities, care delivery partners who we work for, right? So there is significant potential here, but this is an essential concern that, quite frankly, as I said, is not going to be a one and done. This is something we are going to have to, as a system, continuously get better about and make it a core part of our discipline. Next slide, please. Here are some examples, and this page focuses on examples of bias that seeps into the delivery part of the healthcare system. The next page focuses on the coverage part. And again, I'm not going to drain these. A lot of these examples we have seen or were previously discussed as well. But all the way from how risk assessments are done, to how diagnostics are done, to treatments are presented, there is inherent bias when we go back and look at the data, when we go back and look at how these outcomes are being applied. Some specific examples here are around pain management, glaucoma, particularly mental health diagnosis, which has, especially since the pandemic, become such an important area of focus. It was always a key area of focus for us. Its impact on medical care, more broadly physical care, has been only amplified since then. And more studies are finding out that when we look at diagnosing conditions like depression and anxiety, and when we correlate that with minority or marginalized communities, there is bias there, right? So these are call outs for us to say, look, exactly as Dr. Hightower and Dr. Sambamoorthi are doing, we need a lot more research in this space, but then we need to take that research and adopt it into how we execute on a day-to-day basis in the delivery systems, in the coverage part of the healthcare system, in the day-to-day business operations, and make sure that we are continuously debiasing, but then also monitoring and validating on the other side of it, alongside the health outcome, what the impact of that has been. If we move forward one more page, this page really focuses on, when we think about coverage, right? A lot of the focus from a bias perspective tends to be on the delivery side, but there is definitely the potential for bias in healthcare coverage as well, whether it's coverage denial, whether it's how we adjust for risk, what treatments are authorized for which minority groups versus not, even all the way in how networks are developed and crafted. And to one of the points that was made earlier, some of the data that's coming forward for national studies is heavily influenced by certain parts of the country. Here in Massachusetts, we are blessed with having one of the best healthcare systems in the country, but it's also a very diverse system in terms of all the way from rural areas to more urban areas. But that's not necessarily true or the case for the entirety of the country. So when we look at network advocacy, that's another important point which doesn't come to mind right away, but the more we dig into it, we find that what coverage is provided is an important factor of what networks exist in the first place, as an example. So if we move forward one more page, please. So, and both Dr. Hightower and Dr. Sambamoorthi talked about this idea of human in the loop. Again, not a new idea, but when we think about it as a health insurer, again, a community-focused single state plan, we are hyper-focused on this idea of any impact of AI-driven outcomes that are reaching a member directly or indirectly, especially when it comes to any adverse actions that are being created or have the potential even of being created, that we view it from the lens of ethics, we understand the context behind it, and we build trust in it. And having a human in the loop, somebody reviewing, whether it's an individual or a team, the outcomes, giving feedback on where these outcomes are in line versus where adjustments need to be made. Because over time, for us to achieve, if you will, the top of the license impacts of AI, we have to develop trust in these systems, and trust will come only from repeated verification, checking, and demonstration that the work of making sure these outcomes that are making their way out to the end consumer and the end member have been debiased to every extent possible. Then if you go forward one more page. So this is really all about, okay, so how do we do that, right? And again, both the previous presenters walked through some excellent examples of specific tools, methodologies, and models, if you will, partnership models with the community, etc., that should be leveraged in this space. You know, when you look at the categories of different biases, and by the way, these categories, we all understand they are not mutually exclusive. They bleed into each other, if you will. One often has manifestations and causes, root causes in another. But when we look at, for example, racial, gender, and ethnic bias, collecting diverse and representative data is not the only solve, but it's an important solve, one that we must not miss, and one that we focus on a lot. When we think about socioeconomic bias, making sure that we are enriching healthcare data with socioeconomic data, social determinants of health data, that's a critical part of it. When we think about accessibility, again, compliance with accessibility standards, all the way from when we are thinking about the human-centered design aspects of this, and really designing and testing for systems where this is built in and not a bolt-on. Language and culture bias, this is again including experts, linguists, people in positions who can understand both the healthcare side of the equation, but also come at it from a explanation in terms of how understandable or within reach the complex language that healthcare itself is can be for people, in addition to all the different language barriers that exist today. And last but not the least, this idea of confirmation bias. And this is where training data, auditing, and really making sure that there is diversity built into the decision-making process around these algorithms is key. Next page, please. And again, this is in summary, right? When we think about what are the different focus area and what are different mitigation methods, this is how we think about, and this is again very much work in progress. Like I said, this is not a one and done, but there are some good ways of thinking about data diversity and representation from a diverse data sets perspective. How do we make algorithms transparent, and that we have to make algorithms transparent? That was a point that was emphasized previously as well. Continuous monitoring and evaluation, easier said than done, but again, necessary part of it. Having a very ethical view of AI governance, and again, within our company, we very much focus on this as a key aspect of it. Community involvement, that was a point made earlier as well, very critical in this space, and ongoing education and training. So again, huge potential of AI in healthcare, but also a good degree of caution that we need to apply to make sure that not only do we not perpetuate any existing biases, that we actually debias existing biases, but then managing for volume, velocity, and variety of data, we don't introduce any net new biases into the system as well. And I think that's it for the content part of the presentation.
Thank you, Mr. Arora. My apologies for my mistake. Thank you very much for giving us an industry perspective. We now have